So I will now thank our speakers who opened the conference for us, and I'm going to invite Marie-Dominique Beaulieu, professor at the University of Montreal, former director of the Family Medicine Department, who will preside the first session. Marie-Dominique. Thank you very much, Howard. Thank you. Good morning. For me, it's an absolute pleasure and honor to have been invited to preside, to moderate the first session, which has to do with the history and the state of our healthcare system. I would also like to wish a happy birthday to the Family Medicine Department at McGill University. I started my practice as a family doctor 38 years ago, so in fact, you were all quite young. At the family unit, the family medicine unit, at the children's, I've still got a lot of colleagues that I've seen today, so happy anniversary. And I had the privilege of practicing for 2 years with the nurse practitioners. McGill was innovating, and unfortunately, it didn't last very long, but now we can see that it's making a comeback. And it was such a privilege, and I realize it now, how this beginning of my practice in that kind of environment was very dynamic and young. You had only been around for 2 years, and it was a privilege for me. So I'm going to stop there. Just want to wish you a happy anniversary. As Howard said, you've got here the opportunity, of course, to hear people who were really artisans of our system. There are a lot of young professionals in the room. They don't know our history, but to know our history allows us to better understand our present situation. We say that the past prepares the future, and perhaps sometimes it can be worrisome, but I think that by better understanding where we come from and what we've experienced, we can find solutions to the challenge that we are facing. So I will introduce our first speakers, and I know them personally. They will do their presentations one after the other. They each have 15 minutes, and I've got the responsibility of being the timekeeper so that you may have a few moments to discuss.
Maioni. Antonia Maioni is Associate Vice Principal for Research and International Relations at McGill University, and also Professor in the Department of Political Science in the Institute for Health and Social Policy. And she will be followed by Leonard Aucoin, who has spent more than 30 years as a strategic advisor in health and social services. He was, among many other things, a member of the Claire Commission that actually recommended the creation of the family medicine groups. So here are your two first speakers. Can you please come? Where is Antonia? So 5 minutes and 1 minute.
Bonjour tout le monde et bienvenue.
Hello, everybody, and welcome. I'm going to begin by recognizing everybody who's organized this conference and who have invited me to speak. And also, I'd like to tell you to not be too scared of the title, which is Health Reform in Quebec from la Castonguette to la méthode Barrette. I feel a little bit ill at ease because Mr. Castonguette is here. And I didn't want to be impolite, but we called it a Castonguette at the time, and that's why I wanted to link up the two little plays on words, the two markers of the history of our healthcare system here in Quebec. You may remember that this Castonguette was something that we used kind of like a Visa card at the time. We called it the Chargex, and that's why the Castonguette came with the Chargex as well. I don't know if this is going to work. Somebody? All right, there we go. Last night, I was inspired.
There was a gala for all of you to celebrate the 40 years of primary care, the Department of Family Medicine here at McGill, and he asked why, or he kind of raised the issue of primary care being perhaps the forgotten child or the overlooked child of healthcare in Quebec. And I'd like to say that I think one of the things that has to happen now that you're 40 is to kind of recognize whether you are the Cinderella or the belle of the healthcare ball. And the reason I suggest to frame it in those terms is that in the past, I think, decade or two, primary care has become to take a lot more place. We can't really call it the overlooked child, but the idea c'est est-ce qu'on va s'assumer? Est-ce que
But the idea is, will we take our place? Will primary care take their place as being the center of attention for the healthcare system in Quebec? One of the things that I would like to begin with is the definition.
Many people today are going to talk about how primary health care in Quebec has changed. The way we do business in healthcare has changed health outcomes. But I wanted to start with a definition of primary care, something that gives you an idea of how important it is. And this definition is from the from CIHI, this idea that primary care is to healthcare what the ABCs are to education, and that is the very foundations of care. I guess we could say it's also like what you need in terms of porridge in the morning, but that didn't sound so great. So I thought the ABCs was a better thing. It's not that it's just that it's good for you, but that it actually is the foundation upon which the healthcare system rests. L'autre définition, évidemment,
The other definition, obviously, is much broader. The definition of how primary cares fit into a global vision of health. That's the definition of the World Health Organization. That brings us to think about primary care like this idea of integration of healthcare with other services, and also the importance of health determinants for the population. So we've got two definitions that bring us to see the foundation on which primary care rests.
Howard asked me to do a little bit of history, which again is a little intimidating in a room where most of the people who shaped that history are here with us today. But let's go back to in the beginning, as I call it, and remind ourselves that for many people prior to the 1960s, healthcare was primary healthcare. That was what most people were accessing, what was the easiest accessible kind of care. As Madame Fortier reminded us in Saint-Timothée, that is what healthcare meant to the majority of the population, was their family doctor and the kinds of care they could receive with him or her, mostly him. So in the beginning, we want to remember that primary care was what was the definition of healthcare for most people living in Quebec and indeed the rest of Canada. And it was, in effect, when governments, when l'État became involved in regulating, but also in financing parts of that healthcare and the access to care, that bargaining started, and that the place of primary care became, in effect, not necessarily overshadowed, but part of a much bigger mix of what a healthcare system was going to be defined as. And these are some of the markers of the Canadian healthcare system that many of you are familiar with. The idea that when healthcare was first became part of what the state did in financing and organizing, the emphasis was put on hospitals, right? Not on what happened outside of hospitals, but on hospitals themselves at the very beginnings of our publicly funded healthcare system. And then when the medical part of care became insured, the idea was that physicians would be involved in this kind of bargaining, continual bargaining with the state, and that in effect there was going to be a compromise. And many scholars of health policy have seen this compromise as incredibly important as a core bargain between physicians and the state in providing services to care. In Quebec, that kind of bargaining took place, in fact, separately for family doctors and for specialists, and so it's very different in terms of how we conceptualize the relationship between the state and physicians in their capacities as well. L'expérience québécoise, par exemple,
The Quebec experience, however, is something that's very unique. And obviously, Mr. Castonguette is here. This is Mr. Castonguette here, just a couple of years ago. It's a picture that is from the Castonguette Commission. For those of you who aren't familiar with the Castonguette Commission, this is the commission that was established in the 60s to study the situation, the state of healthcare in Quebec, before making recommendations, before putting in place a system, a health system. So it's very interesting that we took the time, actually, to give this task to Mr. Castonguette to finally come up with a diagnosis as to what we should do to have a system that would work and that would meet the needs of Quebecers. And the report of the Castonguette Commission is very interesting because the diagnostic that he came up with is very explicit when it comes to the specific needs of Quebec. So we have to tell ourselves that this was in a period where all provinces in Canada were building their health plans to be eligible for federal financing, but in Quebec, the emphasis was always put on specific needs, so to really target a diagnostic. And what we saw in this report, the solutions that are brought forth by the Commission, is a very broad view, a view that sees health as part of a much broader social safety net, and that's unique amongst all provinces in Canada at the time, in the 60s. This idea that we should have a place for health with other social services, and in fact, that it should be a system that is integrated. And that is the importance of this Quebec model for Medicare and social services. I don't know where Mr. Castonguette found his muse. He may tell us. But one of the things that's very important in the way that we look at primary care in this integrated healthcare system with the networks and everything that we've got in the reform is obviously this model here.
In the room, and this will be a very familiar model to some of them. This is, of course, from Lord Dawson, who was the person who laid the foundation of the National Health System, the National Health Service, in the UK. And Lord Dawson's model is a hub and spoke model, but it's also a model of integrated care, it's a model of networked care, and it's a model of regional care. And in a sense, this model, which dates from the 1920s, is something that we see played out in terms of how primary care is designed, or was designed, in the 60s and 70s here in Quebec. The other part of the Dawson model that's important for those of us who study primary care is that it rested on the assumption that what most people need in a healthcare system is primary care. And it's this idea that there is a pyramid of care that needs to be respected, regionalized in terms of the needs of specific populations and regions, but one that in effect tells us that any functioning healthcare system rests on primary care. La loi de l'assurance maladie est en fait
Now, the law on medical insurance and the law voted in 1971 are inspired by that conception of primary care and the importance of primary care. Here we see once again Mr. Castonguette, who is giving the first carnet santé, he remembers that, I'm sure, to a woman who just gave birth to her baby. But the idea is that in this system, in this law, we still see the remarkable innovation in Quebec of having an integrated vision of healthcare and of social services. And since, obviously, we haven't stagnated, once again, we have the two architects of these two reports, the Rochon report and the Claire report. But the idea, and they're here with us, but the idea is at the beginning of primary care in the design of the entire healthcare and social service system was evolving and has evolved since. I don't have the time to describe everything that's going on in these commissions and the laws that followed, but the idea is that we continually questioned what did we have in the original law and if we've actually reached the objectives set out by this law in the past. We've also had the waltz of the ministers, and I put this slide up because Quebec is unique because we've got so many doctors who are ministers of health, and I don't think there's any other province or any other country perhaps in the world where we've continually seen not only a waltz of ministers, but a waltz of health ministers who were doctors. But things were about to change. A minister that's unlike any other, Gaetan Barrette.
Dr. Barrette, excuse me, into the healthcare system in Quebec is something remarkable because we have here a physician who also has a vision that is perhaps colored by an understanding of the healthcare system that has not necessarily been shared by previous physicians who have come to play that role. One of the things that's interesting about Mr. Barrette's tenure in office is that, as Howard mentioned, we have had 2 new laws which for the first time I think kind of are a bit of a break with the past. I mentioned that what we've seen in the Rapport Claire and the Rapport Rochon was a sort of thinking about how do we remake the healthcare system to either get back to the objectives of the 1970s or to reform it in that way. The laws that Monsieur Barrette has put forward are in many ways a break with that particular model. And I don't have the time to review all of the diagnostics and solutions that are presented by these laws, but suffice it to say that they are based on premises that see what the reform of primary care, or how this will affect the reform of primary care, in very different ways than in the past. We have to think about whether, for example, Bill 10 is a good diagnostic or not, this idea of bureaucratic waste, the layers of decision-making, and whether or not putting into place a system that, in effect, seems much more concentrated in terms of decision-making is necessarily the answer. Hello, I'm in charge is something we might want to think about as we think about how Bill 10 is actually being implemented today. The second bill that kind of changes the channel, changes the conversation about healthcare reform in Quebec is, of course, Bill 20. And here, the impact on family medicine is also direct. It's the idea that it's a very laudable idea to improve patient access to physician care by, in fact, going the extra mile on the creation of GMF. So the creation of groupe de famille, of family medicine groups, is something that, in effect, Bill 20 takes to another level in terms of how the rostering of patients in those groups will happen. But again, the question is this a good way to diagnose what's going on and what's needed, in particular in family care? So ça, c'est la caricature qui démontre un petit peu.
That's the caricature that shows the vision of doctors of what this reform means for them, and we'll have lots of time to talk about it later today.
Where did Dr. Barrette find his muse? This is a good question. Many observers, and I think myself being a student of the US healthcare system, think that much of that, or some of this, comes from what we call the Kaiser Permanente model in the United States. And for those of you familiar with this model, it's a model of integrated care, but it's not only a model of integrated care on the left, as you see, that triangulates in terms of how healthcare is delivered, how healthcare is financed into an integrated and coherent whole. It's also, if you look at the right, what we call a vertically integrated system. And the problem is that Quebec, or the system that we have here in Quebec, is a publicly funded, population-based healthcare system. It's not necessarily a vertically integrated system in which, as in the US, Kaiser Permanente actually owns and runs the healthcare system. Its healthcare system. I think, therefore, that we're moving towards a perfect storm in which we see a shift away from regionalization, community-specific organization, and participatory engagement, which were, in effect, the foundations of the healthcare system and primary care in Quebec, to something in which stakeholders, at least, find that they may be disenfranchised or that their voices are much less heard, and which takes away from the core bargain, which was about physician autonomy and public regulation. C'est pas moi qui a écrit ça, mais
I did not write this, but this is all the little ads, or the these are the things that Howard sent me over the past month. So I thought that perhaps I was going to show them to you. I know that Mr. Dubuc is here. But if we want to say what has happened with Bill 10 and Bill 20, was it a success? It depends who you ask. If we ask observers in the media, there appears that there's a problem. There's a problem in the structure of the law, but mostly in the implementation and the political leadership behind these laws.
Scholars ask, why do bad things happen to good policies? And I think some people in Quebec today are asking, why do we end up with flawed policies from what are perhaps good ideas? I was going to give you a class on health policy, but I've run out of time. But I want to remind you of 3 points as I finish. One is that there are a lot of different ways of thinking about policy change. My colleague Carolyn Toohey at the University of Toronto has developed these different models. I think that in what we're looking at more recently, we're looking at the Big Bang approach, which is the mobilization of authority about changing the system, whereas in the past we've seen more of the, let's see it here, the blueprint model or even the incremental model. So we are in a different policy setting today than we were in the past. The second thing is that we're in a different policy environment. This is the policy environment slide that I showed to students in first year medical and dentistry, the fundamentals of medicine and dentistry. And when I put up this slide, one student asked me, well, what's in the middle? It's a void. And I think that's why we have to also think about what are we trying to achieve in terms of our healthcare reform? What is it? Where is that sweet spot in the middle? Thirdly, just to remember that in the policy cycle, this policy cycle, which is well known to policy analysts throughout the world, the real emphasis is not the kind of discrete elements of that policy cycle, but who feeds into those elements at different time. So who is involved in agenda setting? Who's involved in formulation? Who chooses? Who gets to choose? Why is implementation so important? And as we've heard since Bill 10 and Bill 20 have come into place, why we need more policy evaluation. Okay, I'm going to leave you with this slide which suggests the 3 aims of primary care reform are really not that complicated. They're about improving population health, improving patient experience, and hopefully reining in the costs of care. It's a triple aim, and it is doable. My colleague Tom Bodenheimer, who spent a lot of time analyzing primary care in the United States, even gives us some building blocks. If you're interested, I can give you that article. But here's what I want to leave you with. Cinderella or Belle of the Ball? How about Cinderella and Belle of the Ball? So I want you, now that we're 40 years old, family medicine at McGill, and in terms of primary care reform in Quebec, to think about it as a moment to take control, to take, in effect, ownership of primary care, and to think about yourselves not as Cinderella, but as the Belle of the Ball. Thank you very much.
Alors, je voudrais remercier le comité.
I'd like to thank the organizing committee for this invitation to speak to you today. Could I have my presentation on the screen, please? I chose to put the emphasis on the last 15 years to give you a critical opinion of the evolution of primary care in... I had the privilege of being part of the Clare Commission with Dr. Bergman and Michel Clare, who are here today. And when we talked about front lines, well, what we could see is there are major accessibility, major problems, coordination, continuity, problems for citizens, but also for healthcare professionals. And we had developed a vision that was, first and foremost, a family doctor. That was at the heart of our vision. And we had 2 recommendations: that the organization of a network, a frontline network, would constitute the main basis. It had to be the footing of the healthcare system. And this network should be based on the double reality of the CLSCs and doctors' offices. And that's why we propose the creation of GMFs, which should work in an interdisciplinary manner with CLSCs, where we found other professionals so for a given population, so that we can improve access, continuity, and coordination of care. That was really what we proposed. 50 years later, GMFs were created, but the development was slow. There was no integrated vision at all, and it was, to a certain extent, improvised. If we look at the development of the first few years, there was no functional link with CLSCs, no efforts of collaboration between the two groups. In the field, we see about the same thing as we saw in 2000. 15 years later, we still have problems of accessibility to family doctors. It's not as bad today as it was a few years ago, but still, it's still present. There are problems of continuity and coordination. It's often the patient who must coordinate professional services, which is quite extraordinary. That's what we're asking patients to do. But there's also the Commonwealth Fund study that was done with the CSBM on the perception of family doctors in Quebec versus the rest of Canada and the rest of the world, or where the opinion is negative. It's the province where the opinion of the population when it comes to family doctors is the most negative, whether it's about access to family doctors, specialist coordinations, or the dissemination of information. And now we're seeing a new start, a new beginning. There's a revision of the management framework for the GMFs, and there are two elements of this framework. Last November, the financing program and professional support for GMFs, that's the Barrette reform that's applicable to GMFs. And recently, a few days ago, there was a program of designation, so the super clinics. What will be the results of this change? And by whom and how will they be evaluated? Well, that remains to be seen. So why so little advancement in 15 years? I'm going to give you my critical opinion. Obviously, I may not be nuanced. I'm going to look at the organization of management and the services. We are still a very hospital-centric system. If we look at the evolution over the past few years, the budgets, operational budgets, assets budgets, CUSUM, CHUM, Saint-Justine, etc. If we look at technological developments, if we even look at biomedical research, there's very little research that is financed for frontline services. If we look at the structure of the network, I looked at the organograms of all the CI3Ss and the CIUSSSs, and you'll be lucky if you find a front line. We're looking at the link between these organograms, and we find absolutely nothing, and that's a recent thing. And we've still got access and continuity problems, especially before and after hospitalization. When we're in the hospital, things go relatively well. It's before and after hospitalization.
C'est que la première ligne n'est pas devenue l'assise principale.
Or has not become the primary basis of our system, which was recommended by the Commission, the Clare Commission. The second factor, I think, is that we have a truncated view of primary care at the Department Ministry of Health. Even today, there's no real vehicle, nothing clear and integrated in terms of what primary care and social services as an integrated whole should look like. People felt that there was a failure of the CLSCs. There was a lot of resistance on the part of general practitioners that there should be this CLSC network. And the CLSCs were hesitant to integrated doctors because many of the CLSCs had a much more community orientation. So we had two models, the CLSCs on one side and the medical clinics, which eventually morphed into GMFs. Two models, two different financial systems, and very little cooperation between the two. We also have a system in which we had centralized union negotiations between the FMOQ, the general practitioners, and the ministry. This kind of union or negotiation is an odd basis for the organization of services. If we look at the situation in Ontario or the United States, yes, they negotiate working conditions, but what there is also, if we look at their missions, they are supposed to cooperate in developing the whole system. If we look at the FMOQ and the FMSQ, it's just the working conditions. And if you're a union, then it's normal that you negotiate working conditions. So there's very little in our collective agreements in terms of how the services of the population are organized. So the front line, the primary services have been reduced to the clinics outside of the hospitals, and the accountability was poorly defined. Now, if we talk about a truncated vision at the top, then the implementation is going to be truncated as well. In 2005, the ministry developed a general service program for primary care. It was centered on the CLSCs and the emergency departments. We're not talking about medical clinics or GMFs as if they were in another universe, whereas the GMFs and the medical clinics were the natural entryways. So this was a bureaucratic approach. It was circumscribed to the financial parameters of the institutions, as if the GMS weren't part of the system. So we had the doctor's offices, the federation, the ministry, and the minister was doing negotiations. And then on the other side, we had the non-professional medical staff, the CLSCs, and so on and so forth. Two silos, different financing systems, and no bridges between the two. And we're behind other provinces as far as electronic patient records. There's very little circulation of information and very little coordination. There's a lot of centralization of decision-making. Antonia already referred to this, but increasingly decisions are made at the top of the pyramid. There's an absence of local governance. In fact, it's been done away with in Bill 10. And these bills are the negation of any capacity of initiatives or co-construction on the part of clinicians and the local population. We had some means of working with the local clinician, and now the power has been drawn back up to the top. So those who have the knowledge locally of their population and the environment are excluded, and there's also the risk of one size fits all. If it's decided at the top, it's going to be standardized. And we're in a system in which innovation is perceived as delinquency, whereas it should be perceived as something that will enable us to improve the system. Now, the command and control approach, this works in armies, but even modern armies have adjusted to the times. It's not just the Barrette reform. We've seen this with other ministers in the past, but it's much more marked today. The message is, I know what to do, what needs to be done. You just have to do what I say, and I will be checking up on you. It's we're working with professionals here, and that reality is being negated. Both the existence of the organizations and their know-how. And managers are looking up because they want to meet the expectations of the people above them, whereas they should be looking downward towards their organizations and their professionals to organize the service to the population. And the medical front line, the primary care, is the Bill 20, which really sums up command and control as an approach. Now, in between 2000 and 2016, there were 7 ministers, 1 minister per 2.3 years. When you change your minister, you change the deputy minister, you change directions, and you reform the structures. So there's an issue of coherence and cohesion. There's no business in the world that could operate successfully with a turnover at the top like this. And in the field, people have a great deal of difficulty finding meaning in these frequent changes. When you talk to people in the field, they say, well, they look at the sky and they say, well, it's changing, it's changing. Let me wrap up. What is the challenge of the future? Well, the die is cast, or cast rather, but can we still have an influence over the rules of the game? Minister Barrette's decisions are made. The question is, can we mobilize key players to ensure true clinical collaboration and management between doctors and other professionals? Shared leadership. We need a primary care sphere that's well organized. We need a populational approach with the appropriate training. We need information systems, and we need to analyze our clienteles and make connections with the public health. There's also the concern with evaluating the relevance, quality, and effectiveness and efficiency of our services and their organizations. We have a finite resource public system, and we have to do the best we can with what we have. And we also have to evaluate the experience of the patient and ensure the patient's role as a partner. And the last, how to ensure local public governance with participants, with citizen participation. Thank you. Thank you very much to both of you. That was great, very interesting. Now we're going to listen to you. We do have simultaneous translation.
In English or French, as you wish. I guess you have to go to the microphones. I see two. Je vois donc deux micros.
I see two mics already.
Peut-être nous pourrions, vous voulez poser une question, peut-être?
There are mics up front as well. Let me give you a mic.
Question. Merci.
Emmanuel Simoni, patient partenaire.
I'm a patient partner. I think that you've drawn a very interesting picture. Both of you have pointed out that the quality of patient experience is a fundamental concern, needs to be in our healthcare system, and especially in primary care. And yet, patients are very much absent. In fact, if we want to use the term, I've heard the word negation of cooperation and co-construction. Patients are the raison d'etre of the health system. And there's a double negation because, in fact, the system is very much turned upward, ready to receive its orders, and not oriented in the direction where it can hear what the population's needs might be. And at the same time, people in the system I should say patients face a system in which there is no entry point. Now, can family doctors provide a solution to this problem through a closer, more collaborative, more constructive approach with patients and family medicine and primary care, that we could come up with a solution to this absence of meaning that you referred to? Well, I think that this collaboration, this cooperation has to start at the local level. Primary care and family medicine are probably the best places to start. And I think if we want to develop a means of reacting and influencing to what is perceived as an imposed model, we need to mobilize people at the base. And it's an invitation for clinicians and patients and managers. We need to work locally to attempt to develop some influence. So I do see that patients need to ally with the GMFs. It won't necessarily be easy, but it's one of the only things that we can do at this point. Well, there are two things, I think, in your question. One is patient participation, which is something that my colleague, Mr. Aucoin, mentioned. But there's also the question of, is the system centered on the needs and the experience of the patient? They're related, of course, but they are two distinct things. If we look at the history of the system, the emphasis was put precisely on how to develop a healthcare system. How are we going to look at primary care as responding to needs? That's what the Castonguette Commission was all about, and the Rochon Commission as well. But also, how does where does the patient find his or her medical home, to use that expression? And what are the entry points? And in all healthcare systems around the world, people are asking them the same questions. What is the doorway, the point of entry? In Canada or in the United States, our system is dispersed, and there are multiple points of entry. Many other systems are constructed in a more logical way. You have your main entrance here, and it's usually through primary care, which are key for the population. And I think that's what we need to work on most at this point. Thank you. Any other questions? I see somebody moving towards a mic. Good morning. Thank you very much. I'm David Belrino. I'm co-founder of the Quebec Health Professional Students Roundtable.
So you've spoken about policy cycles, and what I'm concerned about, what my colleagues are concerned about, is that the reforms that we're seeing today, let's say they don't have the effect that the minister says they will. The concern is, for example, with respect to interdisciplinarity, we see some funding for nurses and for links with a pharmacist, but it's a far cry from the integrated interdisciplinary clinics that we see in other countries like Sweden, where you actually have a physiotherapist and a psychologist in the clinic all the time as part of the care team, instead of just equivalent in nurses or equivalent pharmacists you have an agreement with. So with respect to policy cycles, if this is the reform we're stuck with for now, this is the one that's been passed, how long do we have usually before we can try and fix it or change it? No, but so it's because we know that these things have inertia. So what is the inertia in a policy like this? And what would be the damage in either trying to fix it quickly or letting things settle before trying to fix it again? So in terms of looking forward beyond Barrette, which will happen, what do we do to sort of, what would be a rational policy course to correct or change or try and enlarge the reforms?
Okay. Apart from everyday forms of resistance, as we say, or civil disobedience, yes, all right. So the idea is that the policy we're stuck with, I think that's, so policy is a living thing, right? And so that cycle is meant, in fact, the way policy analysts see it, as a living thing as well. So it's not that we're stuck with the policy, except that it's interesting that in parliamentary systems, when there's a majority government and things are passed, it's difficult. I mean, the changes have to happen at the implementation stage because the policy is already passed. But I think in the implementation, right now is an interesting time to actually see where les failles dans le système se trouvent and how to improve it. The problem is that takes evaluation. So we can't actually fix what we know to be not going right unless we have evaluation of how it's been going. So I think that's the big challenge, is how do we find the ways to evaluate how the system is changing to be able to make the necessary changes, to the fine-tuning in terms of better implementing it.
Je suis d'accord avec ce que dit Antonia et je pense que...
I agree with what Antonia said. I think it'll be important to look at implementation and look at the faults within the system, or the cracks. I think it's Leonard Aucoin who said there are cracks, but cracks let the light in. And there will be spaces where we'll be able to change things for the better. Thank you. Anna Larouche here. Two questions or comments. In the field, family physicians are asked to meet certain targets that they're not capable of reaching. The results are contradictory. If they want to avoid being penalized, but the feeling is increasingly that patients are hard to come by. There's a paradoxical effect here, which leads me to think that customer service are going to be the solution for these doctors to keep their clientele. A lot of groups are in the process of building clinics. This is a perception, it's not scientific. The second comment is related to the first question raised by the patient. I believe that the next thing that we're going to see is going to come from patients. Patients are going to take charge and express their needs thanks to information technology. Patients know a great deal more about their health condition than they did in the past. They know about their symptoms. They know a lot of things. Information technology will be the basis of the coming revolution. Perhaps you could respond. Well, on your first question, how doctors will build their clientele, I don't know enough about the detail of the agreements, but in general, in any agreement, depending on the incentives it contains, people will change their behavior. I can't go farther than that because I don't know the details. As far as the role of patients and IT is concerned, yes, of course. I think that the power of patients will increase because they have more access to information, good information, and they have an important role to play. It's underway already. And there will be natural alliances, I think, between professionals and patients. That's something, if we want to influence how policies are implemented. First mic. Thank you. I'm Marie Girouve, director at the University of Sherbrooke Family Medicine and Emergency Medicine Department. Thank you for your presentations. At the present time, we're going through a rather difficult time in the field. It's good to have an opportunity to have an overview from 30,000 feet. We don't have a grasp of the political agenda, and the political agenda is dictating a time frame that has resulted in a lot of cynicism and a feeling of powerlessness, because the objectives are very difficult to reach and the time frames are too short. Clearly, there's a tremendous amount, there's a lot of incongruity that people see, people who are out in the field working and who feel that they are being muzzled. We have to come up with solutions, of course. There are patients, of course, electors, voters, but also how do you see the role of the universities, the Faculty of Medicines, and more specifically departments of family medicine? We're working to train more and more family doctors. What are the other avenues that we can develop? Well, one observation is that the only voice that we're hearing on the medical side in recent years are the two medical federations. we don't hear any of our voices. The AMQ has spoken, but feebly. And academics have a social and political role to play. If you don't speak, if you simply submit, there has to be another voice than that of the two medical federations to say, whoa, there are other factors that need to be taken into account here. And I think you have an important role to play. The universities have credibility. You also have a certain neutrality. And you can support what you say with facts. So I think that you need to raise your voices, because the only voices that we've been hearing are the two federations on the one side and the minister on the other. And as a public message, well, the outcome is not good. Whereas if there were other voices, the voices of reason, we would have a much more balanced debate. In addition to neutrality, on the academic side, there's also the evidence. Your university researchers are an important source of information. So it's not just the voice, but the knowledge, the credibility. But we're in a food fight at this point, really. A turf battle between the federations on the one side and the minister, the person of the minister, Dr. Barrette. So how can we change the debate? Well, by injecting knowledge, the results of research, and that's up to the academics. Okay, I've asked for permission to go over a little bit because there are several people who would like to speak. So please ask your questions concisely so that we can hear from everybody. Thank you very much. Patrice Auroy, Director for Regional Medical Affairs at Pfizer Canada. I would like to follow up with the comments of the doctor from Sherbrooke who just spoke, and to get a little farther away from the problem. Well, problem, I'm not sure whether we should refer to it as a problem, but there are political orientations. Can we put that a little bit aside? There are turf battles, yes. Can we put that aside and look at what's being done in the universities in terms of the training of health professionals? I think there's enough evidence that shows that we need an interdisciplinary approach, and we know that it's important to measure impacts on the population that's being served. So my question is, in our medical faculties, in the nursing schools, the kinesiologists, and so on and so forth, what is being taught to people in terms of what is expected of them, and how they should work with their colleagues, how they should measure the impact of their work on their patients? Because it's through education that we're going to achieve change. It's fine to look to politics for change, and that's part of it. But the real change will come through what is taught to the newly arrived students. Well, our Dean of Medicine is maybe here. Madame Fortier is here as well. But as a professor, I would say that interdisciplinarity begins with mutual respect for our competencies. When I teach at the Faculty of Medicine or in kinesiology or occupational health therapy, what I'm struck by is the curiosity of the students.
To know what it is that they can learn from political science, from policy analysis, that will help them do a better job. Et je pense que c'est ça, c'est la curiosité et le respect mutuel.
I think it's the curiosity and mutual respect. It's true that interdisciplinarity in the field starts with the way we're trained, the way people are prepared to go out and work. And over the 20 years that I've been at McGill, I've seen a radical change. Thank you. Yes, madam, at the mic at the back, you've been waiting for quite a while.
Comité de usage.
The Users Committee at CUSUM.
First of all, users committees have really improved things at the MUHC. We have patients engaged in many, many different committees, and many people have told us that it helps. I am extremely worried about super clinics and things like that, and how patients will be engaged in helping make decisions. Can someone tell me what a super clinic is and what will happen?
I don't know what super clinics will be. Okay, we only
It'll be
heard
super.
We only heard the minister he says that they will be super. We don't know the details. Okay, but it's clear that your apprehension is probably well founded. We'll see what will happen, but I don't have any more answer than you have.
So, but I think this is an excellent answer, because the idea is, we know that it's based on a good idea, right? So my question was, why do sometimes bad things happen to good ideas? Well, maybe it's a good idea, but the problem with super clinics is that it's based on the idea of efficiency, which is one component of a well-running healthcare system. But the problem is, where does a patient's voice come in? Where does continuity of care come in? Where does the organization of people who actually have to staff these clinics come in? That's a different question. And I think that it depends on what is the rationale behind this kind of a reform or this kind of a change. In this case, it's efficiency, but is efficiency the only thing that we want from this particular part of our healthcare system?
Merci. Il reste deux personnes. Je vais vous demander d'être...
Thank you. I will ask you to be brief so that we can hear from our two questioners. Marion Dove.
Medicine residency program in the Department of Family Medicine. Thank you both very much for your presentations. They were very helpful to me as a teacher of family medicine to understand why it's so chaotic sometimes to teach family medicine, because every 2.3 years there's a new policy and new regulations. So I was very interested to hear that you think that the universities and departments of family medicine have a strong voice to play. I completely agree. When Barrette came into office, my medical students were all saying, I'm not going into family medicine. I'm even wondering if I should have chosen medicine because I wanted to do family medicine. And now I'm feeling that we're being completely poorly treated. Residents this year, luckily at McGill we matched fully, but the only unmatched residency spots in family medicine in all of Canada were in Quebec. So I think that students and residents are speaking with their feet about the reforms that are coming, and I guess when we think about making a statement and being part of that public debate, I'm wondering if you have specific concrete ideas about how we can phrase that, because we know that doctors don't get a lot of public sympathy, and I completely understand that we're in the top 1% of the income earners. So how do we phrase our concerns about the healthcare reforms from students and residents?
Merci.
One thing is sure is that your revenue shouldn't be the main argument. Okay, what happened in the last years? Okay, is that every time we heard, the focus was on revenues. Okay, it's a lost cause for you. It seems to me that you should be much more, your dossier should be on access, on how to make sure that primary care is what it should be. Okay? You know what it should be. You have data, you have knowledge. You should focus, your intervention should be focused on that aspect. And how people will have access to what should be done in primary care. Too much has been said about revenues.
And I think that, I mean, just to kind of go back to some of the things that I highlighted in the presentation, if you think about the healthcare system that rests on the foundation of primary care, that should empower primary care physicians and their teachers to sort of think about how important it is, not just as a building block, but the very foundation of the healthcare system, how important it is to individual health and to population health. These are things that you're not making up. These are things that are actually there and known. The other thing I would say, though, is that, I want to go back to Madame Fortier and Saint-Timothée. Physicians, family physicians, are, in effect, le cœur du système de santé, même avant qu'il y avait un système.
They were at the heart of the healthcare system even before there was a system.
Conversation about, you know, les revenus, qui fait quoi. We kind of forget that, in effect, the care part of the healthcare system rests in the hands of primary care physicians, and that they should be confident, right? They should have the confidence that they are, in effect, not necessarily the weight of the world on their shoulders, but they are, in effect, the front lines in a very positive way.
Merci beaucoup. Il ne reste qu'une minute. Je ne prendrai que...
We only have 1 minute, so I'm only going to take the lady who's been waiting for a long time, and then we'll go to break. Please go ahead. Dominique, family doctor at the GMF, the Queen Elizabeth GMF. 2 weeks ago, we had the Fresque, the forum for students in health, and I think there were 27 associations represented, students in different fields of healthcare who got together for 2 days to look at all the proposals that were done when it comes to organizing frontline services. They voted, I don't know on how many propositions. It was beautiful. Mr. Barrette arrived and he told them 2 things that were quite surprising. The first one is that Bill 20 was there to force doctors to work, but then said generally that students lived in the world of unicorns and there wasn't enough money to finance all of their wonderful proposals, so he could not take them into consideration. So my question is, what's the issue exactly? I think that this closes out the session wonderfully. Thank you very much. So we'll go to break until 10:20.